Painkillers. This is 2001, current century. Drugs are getting more bad press than ever before. This lecture is designed to help your patients from becoming a pillhead. It's not very flattering, but people take more than that because painkillers can be deadly. It's a practical session. Let's talk about some of the general overview and benefits of MET. In the handout notes, which most of you have not read probably because you got them this morning on a CD, I have these things listed, and also I'm referencing the 2 chapters I wrote in the textbook Pain Management, which is the textbook of the Academy, where this lecture is updated from that, but some of this preliminary information comes from there. So you don't have to write all this down. Buy the book, by the way, if you don't have it. It's certainly safe, and that also protects you as a practitioner. Interestingly, it's much more efficacious. I have some fantastic data on the efficaciousness of CES, cranial electrotherapy stimulation for depression, above all the leading antidepressive drugs. It's about twice as effective as the most effective antidepressive drug, and I'll go over that right after lunch. I have some good science on that. It's relatively easy to learn, and you can go buy a hamburger at McDonald's and like the person who serves you and hire them to work for you and under a physician, supervisor, and operator license. The more education that person has, obviously, the better. However, medical education, besides knowing anatomy and disease and all that, is not an absolute prerequisite. So you can have staff do this, as opposed to neurosurgery. You have to do that yourself. Interestingly, it's the last thing that's used, but it's effective in cases refractory to conventional care. Medicine is the only thing I know where you do the most radical intervention first, and when that fails, you try something conservative. And then it often works. Certainly reduces the need for addictive medications. And of course, the biggest problem with drugs is not addiction, it's not even side effects, it's tolerance. And with microcurrent electrical therapy, there is no tolerance. I, by the way, coined that term microcurrent electrical therapy in 1985, in an article I published with Joe Mercola, and whom many of you might know at mercola.com, the second busiest health site on the web. And I specifically didn't trademark that term, so it would be commonly used. Some people use the term MENS, microcurrent electrical nerve stimulation. First of all, it's not necessarily nerve stimulation. Second of all, that is a trademark for Monad Corporation, and therefore indicating a specific device. So I introduced the word MET into the literature so that everybody can use it. It may be applied on a schedule basis or as necessary, and it may be self-administered by patients at home under your directions. It requires an order by a licensed practitioner, although not necessarily a medical doctor. And it's incredibly cost-effective compared to drugs, and I have information on that, again, right after my lecture right after lunch. We're going to hear some lectures. The next group of speakers, at least 2 of the speakers, will be talking about treatment of headaches. We could also treat nerve, muscle, and joint pain. Cancer pain responds very well. Using it for greater than 1 hour a day at a low current of 100 microamps and nothing more, we could heal fractures and decubitus ulcers. We definitely work well in dental pain. Hematomas have gone away overnight, although it's contraindicated in pregnancy, although that's questionable, and there's now good research on rats about that. And but I have 2 absolutely perfect, beautiful, incredibly healthy daughters. One is 3.5, one is 4 months old, 3.5 years old, and one is 4 months old. And my wife used electrical stimulation and water birth as the sole means of treatment during labor and delivery. Sprains, strains, and spasms go away very quickly with a few treatments. We do a lot in sports medicine. I personally worked with a lot of pro teams. We've seen paresis, partial paralysis, go away, sometimes as quickly as one treatment. Certainly postoperative pain, and we also treat scars, which Dr. Dietrich Kleinhardt, some of you might be aware of, called neural therapy, and in acupuncture called the mother-son law. I'll discuss that in a moment. You can treat trigger points with electrical stimulation. For some things like chronic fatigue, fibromyalgia, reflex sympathetic dystrophy, and phantom limb syndrome, we find that it's not helpful to treat the body, we only treat the brain. We do want to watch out with old pacemakers, and I don't know if there's any of those left, frankly, because usually they change them out when they have to change the batteries. So it's the pre-1998. Since then, there's been electromagnetic compatibility legislation passed so that devices have to adapt to each other. Last time I spoke to a pacemaker company about using electrical stimulation with their pacemaker, they said anything other than a blowtorch directly on it will not affect it. When was the last time you walked into a restaurant or saw a sign that said microwave oven in use, to caution pacemakers, people with pacemakers? Pregnancy, the biggest problem is unsubstantiated legal arguments. My wife used electrical stimulation throughout her pregnancy, but only on her brain, not on her body. You don't want to press on the carotid sinuses bilaterally because, well, you know why. It could cause skin reactions, redness to serious burns. I know people who use electrical stimulation. There are ways to deal with these problems and avoid them, but I know people who use it even though they have bad skin reactions because it helps so much. Patients should have their own electrodes. You shouldn't move electrodes from one patient to another to avoid contact dermatitis. And of course, there's the standard disclaimer in all pain interventions that it may mask pain of a progressive pathology. People shouldn't drive or operate heavy machinery during, or in some cases after use because they might be too relaxed, during use because they might get a jolt or become too relaxed, depending on what you're doing, and therefore get an accident. It can cause headaches, vertigo, and nausea in some people. That's mainly treatment of the head. Fear of electricity can cause panic attacks. I consider lowering essential hypertension a plus. I've been able to control blood pressure in just about everyone with electrical stimulation of their brain, and it has a homeostatic control over time, long-lasting effect, and if as long as it's essential or idiopathic. You all know what idiopathic means, right? It's the doctor's an idiot, it's pathetic for the patient. Yeah. Anyway, it won't help hypertension if it's due to kidney or heart problems. It can cause vasodilation, so that could be a problem in some cases. I mentioned before that you want to look at double-blind research. We have a lot of that. I published a book that's an annotated bibliography. It's a review of 126 human studies and 29 animal studies, plus there's been meta-analysis and that sort of thing. But survey data is also very helpful in getting a breakdown. Now this is 47 physicians reporting on 500 patients in 7 different symptom categories. The number of patients in each category add up to more than 500 because there's no such thing as pain without a mood disorder. Even if you stub your toe, you don't just say, oh, I just stubbed my toe, no big deal. You have a moment of anxiety, even though you can then process the information, realize it's temporary, it'll go away, and you can get on with your life without rushing to the hospital. But anyway, you'll see very few patients were made worse, very few had no change. Anything under 25% improvement is considered insignificant by drug standards. So if you look at significant, we're pretty much in the 90s. The only one is insomnia, down here at only 79%, which is pretty good. Also, if you add the charts at 50% and up, you'll see that's by far the majority of the people. And if you add 75% up, you'll see pretty impressive results too. This is a survey on 2,500 people. We're about to publish again at 5,000. This was actually published in the American Journal of Pain Management. And 93% overall efficacy in pain. That's 1,949 cases. And we see in the various types of pain that the figures hold at a very high level. We also see specific breakdown in pain, fibromyalgia patients. Now, the inclusion criteria for this was people had to use electrical stim for over 3 weeks, because we found in research that it could take 3 weeks to get a good therapeutic effect. So this was patient surveys, actually from warranty cards, who actually sent in their warranty card, which is a fraction of them, and then who actually filled out the survey and who waited 3 weeks or more. It says wait a month, but you know, the obsessive compulsive people send it one day. And I've never sent in a warranty card in my life, so I can't really criticize people too much for not doing it. Anyway, here again, you see the very significant results. So going on to the practical protocols. The first thing we need to do is analyze the pain, and that's not necessarily just naming the problem. You need to know the anatomy involved, for sure. You need to know what positions exacerbate the pain, because you're going to use these as indicators during a single treatment session. Of course, how bad are they on a 1 to 10 scale right now? Actually a 0 to 10 scale. Well, if they have pain, well, it's a 1 to 10 scale. And 0 being no pain, 10 being the worst they have experienced. And you want to note any obvious signs. Orthopedic neurological tests are certainly handy there. And note any special symptoms that the patients report. Also, don't just focus on one area. Sometimes you have to treat everything that's wrong with the body, even if it's only for 20 seconds, in order to get results. I have been unable to get rid of a headache until I treated a toe, for example. But I have, and that was in a dentist's office, but I was able to justify that because I remember a Woody Allen movie where he said that he had a cavity so deep that his dentist sent him to a podiatrist. So you can do that. Note all scars and old injuries, because we are balancing things, and we may have to treat it all. Then you have to prepare a device. I did make a financial disclosure for this lecture, because I can't talk about protocols without talking about a specific device, and I am a little prone towards my own technology that I developed and believe is most effective. But whatever technology you use, in this case we use felt electrodes. We wet them with a conducting solution, which conducts better than saline, and it also opens up the skin resistance and allows the current to penetrate better, or you can use saline in a pinch. We use a low frequency, which is really a variable waveform composed of a number of frequencies. And we use a higher frequency just to hammer at the area for inflammatory joint disease and remission. What did I just say? If you have rheumatoid arthritis, for example, during exacerbations, the patients don't like it, but exacerbation of an inflammatory disease is heat, redness, pain, and swelling. You have hot fluids in the joint areas. Hot fluids conduct electricity well. It's no trouble to treat. When it's a dry joint, it's trouble to treat. So we hammer at it for about 20 seconds with a higher frequency, and then we turn to a lower frequency for a long-lasting therapeutic effect. For pain on the body, when we're using probes, we generally treat at, relatively speaking, a high current, 600 microamperes. And we do this at 10-second intervals. This is my entire protocol right here. If you know this, you can do it. First, you treat in a big X beyond the area. And I'm going to go through the body with demonstrations of this. The big X is 10 seconds, 20 seconds. You're connecting probes. I'll show you pictures of this. Then a star in 3 dimensions through the area. So on the knee, for example, a couple of obliques, an AP, anterior, posterior, medial, lateral, side to side. Treat the opposite side, even if it's asymptomatic, but briefly. And then you connect both sides. This treats the dermatomes, myotones, and sclerotones, and is essential, and in fact, the most important step, and the one that 90% of people ignore because they're used to treating the area of pain and just having tunnel vision and looking at that and not seeing the rest of the body or considering the body as a physiological whole controlled by the nervous system and other means that I talked about in my last lecture. I'll get back to considering the anatomy in a moment. And also you have to press with the probes, not just touch. You should reevaluate pain every couple of minutes. I stop when the pain is gone, and it's rare that it takes me more than 5 minutes to get rid of a pain. Now, when I said don't treat part of a muscle, you know when someone comes up behind you when you're tense and massages your trapezius a little bit, you say, oh, that feels good, but it really has no therapeutic effect because it's just this part of the muscle. So you don't want to treat it with probes this way. I like to anchor one probe here between the trapezius and the clavicle, this nice little triangle there when I treat the back, and I move the other one around this side of the trapezius about 6 places at 10 seconds a spot, so that's 1 minute. And then I do the same on the other side because, remember, we always treat both sides. And that will get the trapezius muscle. But if you don't know that, and the person says it hurts here, and you just treat right around the pain, you'll have missed the boat and you won't get results. And it's very important to connect the both sides. Sometimes if I'm in a real rush, I'll throw that in. This is the dermatome charts. Some of you might remember these things. Some of you might look them up. For example, if your knee hurts, you might want to treat around L4 in your back, or you don't even need to know it. You just need to stick probes here, and that'll get L4. So, and again, also the myotones for the muscles and the sclerotones for the bone. This is a simple analogy or example. This is the 4 steps. Treating in a big X, this is for a knee problem. Then you're treating at various angles. Now, keep in mind the patient's posture. This is a 2-dimensional treatment. You want to direct the current through the problem area. For example, picture in your mind a line going between the 2 probes, and that line needs to go through the pathology. So this won't work. However, the same treatment position here and here with the probes will work if the patient flexes their knee. You see, because that becomes three-dimensional through the knee. But if I hold it straight and the problem's in the posterior knee, I missed. So keep that into account. This is treating the opposite side for 10 seconds, even though it's asymptomatic, and this is connecting the 2 sides. Now, I like to talk to people while I treat them, so I follow a pattern. I'll box in the knee. Superior laterals, I'm going to use simpler terminology because we have a multidisciplinary audience, which is harder for me. What do you call this? Above and outside, above and inside, below and inside, and below and outside. So you kind of box it in, and this, again, sends it through the spine. It doesn't send it through the space like I've drawn it between the legs. It sends it through the spine, so you're getting the lower part of the central nervous system. Now, if we count, this is 10 seconds, 20, 30, 40, 50, 60, 70, 80, 90, 100, 110, 120. That's 2 minutes at 10-second intervals. And that is often what is necessary to get rid of pain. However, at this point, you reevaluate the patient based on the original criteria, like we just discussed. For a knee example, patient squat down and note the level of pain during the range of motion and how far they can go pain-free. If they're pain-free, you stop. If they're not pain-free, you continue, but you may follow the pain, which may move around. So for example, if you treat a couple inches above the knee, and if you treat the knee like in this protocol, but the problem's a couple inches above the knee here, you missed. So you have to take all that into account. Going through other examples, this is basically the same as the knee, except it's for the upper extremity. Now, the only thing I'm going to mention on this chart is in carpal tunnel, and this is in the book, Pain Management, which if you don't have, you should buy again. I'm going to keep selling you that book. That's, I'm sure the Academy sells it out there. This is what we found. Carpal tunnel, from a surgical point of view, is a nerve entrapment, but from electromedical intervention, it's a median nerve problem, and therefore we treat longitudinally along the nerve. So this way works, this way doesn't. And if you recall, and I didn't point it out earlier when I talked about results, we got 100% significant, which means better than 25% improvement in this condition. And we can usually manage it without surgery. This intervention, done on occasion, plus B&E vitamins, usually will take care of the problem. Back's a little more complicated. This is the same spot I mentioned before between the clavicle and the trapezius, going down past the area of pain. If it's just upper back pain, this electrode might be here, but in this case, we're doing the whole back. And then these are 3 views of the same thing. And this guy doesn't have droopy butt. It's just the picture is bent back. So this is showing treating through the spine. With other forms of strong electrical stimulation that's been used for ages in physical therapy, which are really applications of force, you could put 2 electrodes, one on either side of the spine. But if you do that here, one here, one here, and one here, it won't work. Because again, you're not going through on a 3-dimensional basis. And then you can also go to side this way. There's no reason you can't go front to back, but side to side works out pretty well. So if we count again, 10, 20, 30, 40, 50, 60, 70, 80, 90, 100, 110, approximately 2 minutes. This, because of Leesor's tract, the dorsal lateral fasciculus, where there's an overlap in spinal segments, we go at the area of pain, 1 level above, 1 level below. And we put 1 electrode near the spine, the other on the contralateral, anterolateral side, which means the opposite side on the side near the front. And for sciatic radiculitis, we hold 1 electrode near the back and we move down the leg. If it's all the way down to the lateral foot, we go that far. Otherwise, we just go past where it is. This would be a grade 4. Keep in mind that this is a 2-dimensional approach, but it gets in because of distance and the size of the sciatic nerve, I guess. So that works well. Another good treatment for low back pain is the acupuncture point UB40, which is dead center in the popliteal fossa, the back of the knee. You put 1 probe on each to treat low back pain. It works like a charm. Okay, for headaches, again, the current does not go through the air here. It goes through the head. But the big X is treating from the head to the shoulders. And this is like a magic release point at the acromions here at the tip of the shoulders. You put 1 probe on each, and it really relaxes the head and neck incredibly well. And this is just a treatment around the neck, which is simple. Cross the TMJ, and you have to turn down the current to treat there. And above and below the temporomandibular joint. And that's a 2-dimensional approach, but it's a superficial joint, and that works if it's not a TMD problem, temporomandibular disorder. This is just general head protocol. And then this is showing just treating through the area of pain. You'll take the probes, you'll wet them real well, you'll push the hair out of the way, and you'll use the same strategy of going through the area. Of course, if it's migraine, make sure you treat both sides of the head, because otherwise it'll reappear on the other side. Okay, if it's a sinus headache, then we can treat across the sinuses. We can also treat lateral side to side here across the sinuses. And just as we evaluate the pain through range of motion, someone might say, oh, my pain's 8 out of 10, and then we treat them, and they say, well, it's still 8 out of 10, but they got 30 degrees, and we treat them again, and now it doesn't hurt. If you have a sinus problem, you breathe in, it doesn't sound too good, and then you do this, and then you breathe in clearly, but it won't last. Sinuses need to be treated otherwise, although you will get temporary. This is for sinus headache. It's not for sinusitis. This is for an ocular headache. Just treat around the eyes. You'll see flashing lights because the optic nerve will pick up the current. Even if the current's turned down so low, you don't feel it. So keep that in mind. This is for an actual temporomandibular disorder, and that is added to the previous protocol. And this is very, very effective in treating this ubiquitous problem that's seen in some estimates as much as 90% of the population, but only in people who talk and chew and or otherwise move their mouths or have malocclusion or any other problems associated with being alive. So this is just treating around it. Remember, the head's 3-dimensional, so you're going through the joint this way, and also putting 1 probe on the joint itself and 1 at 3 branches of the sternocleidomastoideus muscle, below the mastoid, the same spot I was telling you about before, and near the sternum at the second intercostal space. Does very well on TMD. I was in a TMD practice in Beverly Hills for a year and a half, and we got really good results with this sort of thing. This was a study on experimentally induced periodontal pain, which is from orthodontic treatment. Orthodontic adjustments cause pain for 96 hours. There's a lot of literature on it. And by using either intraoral stimulation for 10 seconds or extraoral stimulation for 20 minutes, we were able to pretty much eliminate that pain on a number of people. And this was actually a master's thesis at Baylor University. The sham treated group for double blind didn't do too well. And then a placebo control group, which is a group to check for a placebo effect in the sham treated group. In other words, neither of these two groups were treated, did not have much relief. Of course, it does subside over a 96-hour period. That was a pretty good study, actually. This is a summary of my probe protocols for the body. And I'm sorry I'm going so fast, but we've got a lot to do. If it's an acute problem, then we don't treat it with the probes. We have to apply self-adhesive. I use silver electrodes at 1/2 hertz and 100 micrograms for at least an hour at a time, but you can actually wear these electrodes all day. These are the self-adhesive electrodes I was just mentioning. This is my daughter Gabrielle Electra Kirsch, my 3.5-year-old, who is the greatest world expert on Band-Aids. I guess they all are. So before and after shot. Okay, so this shows standard electrode placements for various problems. The red area is the area of pain. So this is just an X across the neck. This is that spot I was telling you about on the shoulders. This releases the whole neck and shoulders like magic. This shows an X over we lowered the electrodes for the X pattern over a wider area of pain, more inferior area of pain. And again, more wider area of pain, we lower the electrodes further, same X pattern. This is showing two possibilities for lower back pain. One is the X pattern across that area, and the other one is going straight across, because you can get this sort of thing going across. You may have to experiment with electrode placements. If we move these down an inch or two, it may make all the difference in the world. But don't put them there, like on a TENS unit. It won't work with microcurrent. This is the spot I was telling you about before, UB40, the acupuncture point, in addition to treatment, local treatment along the back. So this is your was it two lead 4 electrode device. This is the sciatic, same thing I was showing you in the previous one, but based on current density, which means if you're doing this clinically with a probe, you're using the same amount of current through a much smaller area, so it's much stronger. So based on current density, the 10 seconds with the probe is somewhere in the area of 5 to 10 minutes with these electrodes. So you have to leave these on a lot longer. You're not going to move these around every 10 seconds. But this is also convenient for the patient's home use. And this is showing the same thing going further down in a case where it goes all the way down to the lateral foot, following the classic pattern of sciatica. This shows an X for the shoulder, or you can use 2 electrodes going across the shoulder. Or if it's a problem with the deltoid, you can go through it that way. Different approaches, always the same strategy. The strategy's simple. Again, these are examples. I can't tell you how many people call me. I put electrodes exactly where your diagrams show. I'm saying, what part of examples don't you understand? Okay, this is the front. This is to treat the whole arm, front of the shoulder to the dorsum, the back of the hand, in anatomical position. And same concept with the elbow, but we can also treat the 2 sides. Here, the medial elbow to the medial elbow, or inside lateral or outside elbow to lateral. Even though one elbow hurts, we're bringing in the neck and some other areas, and this is a very effective method. I usually go to this method first, to connect the 2 sides. But again, don't put them like that next to each other, unless you're treating a skin injury. Same thing as before for elbow pain instead of full arm. This is the wrist treatment. Remember in carpal tunnel, you go longitudinally from the palm to posterior elbow. And this will do wonders. You can also treat the wrist because there's pain there, but this is the one that's going to really accomplish something. And this is using the whole arm. But again, don't put them like that.
This is only a temporary pain
Not
relief.
necessarily. It could be cumulative. It depends on the pathology. I mean, the etiology will determine how many treatments are necessary. And I'll take questions at the end, please. This is treatment of the whole arm by connecting the two sides. Again, look at the symmetry of the electrode locations. This is to treat a finger. That's pretty easy. If someone has rheumatoid arthritis, for example, and all their fingers are connected, I'll just stick a probe or send them home with electrodes and put them on one on each thumb tip and then move to the next finger, the next. So I could treat the hand in 50 seconds. But this is for one finger. Same strategy through the hip. It's an X. Also, one hip you can do across the two sides, either in an X or directly across, whichever one works best, really. This is showing treatment of the knee in an X or medial. Her position here is a little strange to see. There's her knee, there's her knee. So they're actually symmetrically placed below the knee, medially inside and outside, laterally. But don't put them there if the pain is here, or you miss. You got to put them there in this particular example. Treatment of the ankle, same deal, an X, or connecting the two sides. Treatment of the feet, if there's a podiatrist in the house, then we get remarkable results in peripheral neuropathy by putting an electrode on the bottom of each foot. I didn't used to actually do this. A podiatrist called us, said he got an Alpha-Stim. He tried it on 11 patients, got 100% pain relief in 11 out of 11. So we started doing this, and we're definitely getting good results. It's already in some books talking about that. This is for heel spurs and that sort of thing. Again, keep in mind the pathology. As you said, if someone sticks a knife in your back, you're not going to just treat the pain around the knife. You want to remove the knife. The same thing with a spur and a motor unit. So you have to use common clinical judgment, which is why this is on the order of a licensed practitioner in this country, but not throughout the rest of the world where it has approval, like in Europe and China and Korea and parts of South America and the Middle East. Okay, I always treat the brain. I'm going to talk about this right after lunch. Don't just use anything on the brain. You have to use a CES device or you won't believe what it'll do to the EEG, but it's not a good thing. This takes generally 20 minutes or so. We use it instead of treatment of the body for the pain syndrome, for anxiety, depression, and insomnia, which is its FDA-approved applications, and also for RSD and fibromyalgia and phantom limb problems. The brain's important. Stop when the pain is gone or there's no improvement after a series of treatments, and or stop when the patient feels stiff. Stiff is a magic word which you can interpret as stop. Often I'll have someone with back pain. I'll have them, for example, flex forward and they'll just have limited range of motion. I'll treat them. They'll have a full range of motion. I'll do something like drop their chart on the floor, say, oh, excuse me, I dropped your chart on the floor. Would you mind picking that up without bending your knees to see if they can do it? And then they say, well, it didn't hurt, but feel stiff. Actually, when I do that, remarkably, I see a lot of people look for their pain on the floor. They're looking for it. They move over and then it doesn't hurt. They start moving around and they look for it, like they dropped it. It's very strange. But I've seen that so often. Treat as often as necessary. In chronic pain, every other day is more effective than daily, except for very severe conditions like fibromyalgia and RSD, which require daily treatment, and some others. But generally speaking, and nobody believes me when I tell them this because, we're a society where more is better. 2 pills are stronger than 1 pill, and so on. So treat it as often as necessary, but not too much, because you're trying to work with the body as a catalyst to get the body to function, assuming that it's a functional disturbance. A lot of this stuff is just muscle imbalance or the idiopathic kind of stuff, which resolves itself and seemingly somewhat permanently. And we do have good long-term follow-ups. Some conditions certainly require daily treatment. I call patient management fishing, because when you fish, you let out some line, you pull it back in, you let it go. And when I was in practice, I used to let people go longer and longer between visits. I'd always schedule a follow-up visit, but it might be 6 months. If we can manage them with 1 or 2 treatments a month in the office, then they didn't need home care. If, on the other hand, they had degenerative joint disease, they needed home care. If they had fibromyalgia and they responded to a treatment, or more likely a series of treatment, generally 5 to 7, in the office, then we prescribe a unit for them to use at home. Watch out for this guy. He causes a lot of problems. Nothing personal for the surgeons in the house, but sometimes you can cause problems, especially if you use a scalpel like that one. And I saw a scalpel like that one at the Surgery Museum at Guy's Hospital in London.
I'd like to make a point that in our statistics in neurological surgery that we frequently have failures, therapeutic failures, and we're not proud of them, either because of error in diagnosis, error in technique, error in management. And we've been told that approximately 50% of patients that attend chronic pain clinics are failed back syndromes, and this is a very serious matter. So we are really looking for effective, efficacious, and cost-effective modalities of treatment. That's going to be very, very critical.
Sometimes the scars can create problems. They function as resistors in a biological circuit. If you have a friend that's an engineer, we have a few in the room here, you can ask them, is it a good idea to pin the resistor on the circuit board, like pin the tail on the donkey? Close your eyes, take a resistor, put it down on the circuit board, and solder it down wherever it lands. Not a good idea. Okay. That's not a good idea. That can change the functioning of whatever electronic equipment it is. And that is true in people too. We've had, if I cannot get rid of a pain condition more than 9 out of 10 times, I can after I treat scars. And I do that by placing self-adhesive electrodes on each end of the scar for about 10 minutes per scar, preferably 4 days in a row, but do 4 treatments within 2 weeks. And sometimes we repeat this in a month or so. After you treat scars, 2 things will happen if the scars are causing a bioelectrical problem for the person. One is the person will feel a lot younger, especially people who are like 70 and 80 years old. They'll often say they feel 20 years younger or half their age. We call it the cocoon effect from the movie. And the other thing is their pain will increase because everything in their body wakes up. They start to function, including their pain. But in every case, when we've exacerbated the pain due to treating the scars, we can then treat the pain using our standard protocols. And the only reason I treat the scars is because the standard protocols have failed. Now, I'm not saying we get 100% results either, but if we don't get results, except in the case I just talked about, we generally don't make people worse. So, in summary, you want to analyze the pain, the location, and the intensity of the pain. Prepare the device according to the manufacturer's instructions or your own experience or information you get, such as from this lecture or lectures. Set the parameters on the device. Treat according to the 4-step protocol, big X, beyond the area. Treat through at various angles, treat the other side, and connect the 2 sides. And don't forget that last step. Then we treat the brain, and we treat old scars and old injuries as necessary. Now, we're just finishing up a study that I'll actually be co-presenting, I think in 10 days after this conference in Houston at the International Society for Neuronal Regulation in Houston. I'll be co-presenting with Dr. Gabriel Tan, who's the head of the pain clinic at the VA Veterans Affairs Medical Center in Houston. We just finished up a very successful study on pain, and and we did a previous study there, and we found with VA people, we had to look for other things besides old injuries and scars. A lot of these people have had multiple injections. So we considered more than 5 injections in a given area to be the equivalent to a scar, and we treated that as necessary. We also found shrapnel in these people. We also found a lot of tattoos, which could interfere with bioelectrical function. So we had to treat all of these things. Now, how many of you came here to this conference to learn things and knew that it might be a good idea to treat tattoos when you came here? 1, okay. So, you know, we sometimes, you learn that from me. You've been in my course before. Okay, that's cheating. So, you know, here's some good information you can take home too. When I come to these meetings, I try to bring 3 things home. So, treating tattoos, isn't that interesting? Okay, some of the research we have is slow development. We have a number of studies on fibromyalgia, which is the, when I started in pain, it was myofascial pain dysfunction. Everybody had that, MPD. Everybody had MPD. Now it's fibromyalgia is the new pandemic. Everybody has that. And we have some good lectures on that in the next segment by other people right here in this very room coming up. This is a small study done at the Integrated Medical Centers in San Diego showing improvement, this percent improvement in tender points, about a third improved, self-rated pain about the same. This was a 3-week study, and this is brain stimulation. A self-rated sleep, feelings of well-being and quality of life really go up. This stuff is remarkable. If you've never tried CES, you got to try it in the exhibit hall. It's great. It'll also make you learn better and feel better from this conference. This was Dr. Licksbrown's study at Robert Wood Johnson Medical School in New Jersey, and this showed improvement in, this showed treatment of, this was a double-blind study. The way we do a double-blind study is we turn the current way down. The higher the current, the quicker the treatment. Sensitive patients, you have to turn it down and treat longer. In fibromyalgia patients, they're sensitive anyway, but we only use 100 microamps for research, so you can't feel it. So you don't know if you're getting stimulation or not. Hence, it could be as well as double-blinded as well as the sugar pill placebo. And so this shows improvement on pain, sleep, feelings, well-being, and quality of life. This is the treatment group. And in 3 weeks, pain only improved a little bit, but sleep improved quite a bit. And so did the feelings of well-being and quality of life. I mean, the goal in pain management, as most of you know, is not necessarily to get the person 100% out of pain, although I try to strive for that, but to get someone to function in society, to keep their marriage intact, to maintain a productive career or at least a job. And so these feelings of well-being, quality of life factors, very important. How someone feels about themselves and where they can function is at least as important as their pain level. There are certainly people with very high pain levels that I really admire. I wonder if I can function if my pain level is that way, or if I go into a corner and shiver. Now I'd probably go see Steve Mann, and he'd help me with that aspect. Anyway, so this is the improvement in the 3 weeks of treatment. This is the improvement in the sham-treated group, and these are a control group to check for a sham effect, and we've never seen one in any of our studies. So these people never actually got treated, but it was a matched group just to see if, for example, everybody in New Jersey's, the problem with double-blind study when you only use 2 groups is what happens if there was great news, whatever great news, I'm not going to make up things. There was some really, really, really good news that day. You know, I always think they should have the 24-hour happy news channel instead of Fox and CNN and all this crap they show. In fact, during the 9/11 crisis, a lot of our patients, and we literally have millions of them considering from a technology, you know, who use the technology, over 10 million people even over the years, but, you know, right now, quite a few. And so many of them called saying, I've lost control of my pain. And we say, how much are you watching CNN? And they say, 11 hours a day. And we say, well, can you cut that down a half hour in the evening to catch up on the day's events? And they would regain control. After the 3-week study, it's not a requirement of science, but we think it's a nice ethical consideration because we don't pay people to participate in our research as opposed to drug companies. We take these two groups and say, we guarantee to participate in, we guarantee you an active treatment. You may get a sham treatment or no treatment, but then after the study, you'll get active treatment with also 3 weeks and no more, but you can change the parameters. You can increase the current or move the electrodes or that sort of thing where you can't do it in a controlled double-blind study. And this is the results we got from these two groups with 3 weeks open clinical treatment. So this would more closely resemble the effects you would get in a real clinical situation as opposed to a double-blind study, whereas these were the effects. In that same study, we showed improvement in tender points, and this is a board-certified rheumatologist. In fact, he was one of the people who published the original diagnostic criteria for fibromyalgia, at least that's been adopted by the American Academy of Rheumatology, the 11 of 18 tender points. His nickname on that study was et al. Placebo controls, the treatment group, and these two groups after the study having far better effects because they were able to have a little more current, which they might have felt and therefore wouldn't work for double blinding, but they got better results. This is changes in various mood scores in the New Jersey study, in the San Diego study, the San Diego study, not the New Jersey study, smaller study. Anxiety, depression, anger, lack of vigor, fatigue, confusion, and total mood disturbance, not temporomandibular. So there was approximately a low of lack of vigor. This is the profile of mood states psychometric test. A low of about 18% to a high of about 1/3 improvement in these factors over the 3-week period. Now, 363 fibromyalgia patients following at least 3 weeks of treatment, and some of these a year or more, showed that of the 363 patients, about 8% had insignificant results, less than 25%. The rest had significant results, and about 36% of the patients had 25 to 49% improvement. About 42 or 3% of the patients had 50 to 75% marked improvement, and 13 or so percent of the patients had 75 to 100% improvement in their fibromyalgia using treatment for at least 3 weeks and possibly a lot more.